Hi everyone, I'm Dr. Roman and I'm a hematologist oncologist, and today we're going to talk about anal cancer. So if you or someone you love is suffering from anal cancer, then this is the video you need to watch. I am going to prepare you so when you go see your doctors, you know exactly what's going on and what questions you need to ask. So stick with me, and by the end of this video, believe me, you will know what is going on. All right, so before we get started, I want to remind you, I am not your doctor. I'm not giving any medical advice. This is for educational purposes only. All right, the first thing we need to do is go over the anatomy of the region. You need to know this. So here you have the rectum, and towards the bottom here, you have your anal canal, collectively called, all of this area is your anus. So what we talk about when we talk about anal cancer is a cancer that develops in this region, not up here in your rectum, because that would be colorectal cancer, a cancer of the colon or rectum. It's cancer in this area, and the important thing is that the cells that you find in this region are squamous cells. So the type of cancer that you develop in this area is called a squamous cell carcinoma. 99% of the times you will have a squamous cell carcinoma. So the first question that you need to ask is this a squamous cell carcinoma? So I'm assuming you had a lump in the anal area, or discomfort, bleeding, whatever the case may be. You went into the doctor, they did a biopsy, and they told you have anal cancer. So the first thing you need to ask is it a squamous cell carcinoma? The thing is, on rare occasions, you can have other types of cancer in this area. For example, a neuroendocrine tumor. You can also have a melanoma. There's other histological types of cancers. But definitely, by far, squamous cell carcinoma is the most common. So the rest of this video will be over squamous cell carcinoma. So that's the first thing you need to make sure, is that what you have is a squamous cell carcinoma. Okay, so let's move on. Right, so there will be 3 doctors that you will deal with if you have an anal cancer. And those are a hematologist oncologist, for example, that's what I am. We give chemotherapy. A surgeon, usually it's a colorectal surgeon. And the third is a radiation oncologist. Do not confuse a medical oncologist or a hematologist oncologist with a radiation oncologist. I'm telling you this because a lot of patients, they get confused with this. So remember, 3 main doctors: a hem-onc, a surgeon, and a radiation oncologist. Now we're going to go over some basic information, and then we're going to get into the nitty-gritty of stuff, the treatment, that is what you really want to know. So just know that the typical age is over the age of 60. Now, I have seen a lot of patients that are younger than this. The nice thing is, and this is the important thing, if you have an anal squamous cell carcinoma and it is detected locally, meaning it has not spread, you have a very high chance of being cured if you follow the treatment the way that it needs to be given, okay? There is no guarantee, but a lot of patients do end up being cured. Now, the next important fact is that over 90% of cases are due to the HPV virus, the human papilloma virus. You need to know that. What are risk factors? Well, immunosuppression, for example, HIV/AIDS, or organ transplant recipient patients. Smoking, that's right, believe it or not, smoking has been shown to increase your risk. Having anal intercourse, having other STDs, because HPV is an STD, so if you have other STDs, then this increases your risk of having HPV. And I can tell you, I call it the bad luck factor, because some patients, we really never find a reason. We don't know why, so I just call it having bad luck. Now, how can you prevent this? Well, really, the best preventive measure is receiving the HPV vaccine, which is now recommended between the ages of 9 and 45 years of age. So ask your doctor about this. All right, so you've been diagnosed, you've been told that you have an anal squamous cell carcinoma, an anal cancer. Now we want to see, is it local or has it spread to another area of the body? And for this, your doctors will likely order either a CT scan of the chest, abdomen, and pelvis, again, looking for metastatic disease. Has that cancer spread? Or a PET scan. I tend to prefer PET scans. I can tell you that for the most part, PET scans are very good at detecting anal cancer, but a CT scan of the chest, abdomen, pelvis is also good. Now, sometimes your surgeon or your radiation oncologist may want a pelvic MRI scan to get a better look at the anatomy of your pelvis. So just keep in mind that chances are you're going to have one of the two top ones, and maybe even a pelvic MRI. So the goal of treatment is to cure you, of course, and number two, to preserve your anal sphincter. Because if you go to surgery up front, most likely you will require a permanent colostomy bag. They're just going to remove your anal canal, your anus. And then you're going to have for the rest of your life that bag on the side of your abdominal wall. And this is what we want to prevent. Now, I do want to tell you, on rare occasions, this is extremely rare, a patient can present with a very early anal cancer. They detected this thing extremely early. And maybe you can be a candidate for a local resection. They go in there, usually through a little camera, and they remove the small little cancer. And if that's the case, great. But I can tell you, this almost never happens. So that's why most likely your doctor will recommend chemotherapy and radiation. And that's what we're going to get into in the next slide. All right, so now we're going to get into the most important slide, and that is the treatment of local disease. Notice I'm saying local because unfortunately, if the cancer has spread, then that's the next slide that we're going to go over. But if you have local anal cancer, then the treatment of choice is going to be chemotherapy and radiation. Remember, that's excluding if you're that lucky patient that presented extremely early where you were able to have that local excision. But unfortunately, that's usually not the case. So the treatment is chemoradiation together. They give them combined. And the treatment is usually 5 to 5.5 weeks of treatment. And the radiation portion is given Monday through Friday. And Saturdays and Sundays, you are usually off. Now, the chemotherapy portion, we use 2 medications. And by far, the most common drugs that we use is number 1, mitomycin. That's given intravenously, and the main side effect of this drug is a decrease in your blood counts. It can decrease your white blood cells, predisposing you to infections. So that's why we monitor your CBC, your complete blood count, your blood test. The other drug is another drug that's called 5-FU, which is given in the vein, or we also have 5-FU in pill form, which is called capecitabine. Now, the main side effects of 5-FU or capecitabine are diarrhea, GI upsets. It may give you some abdominal discomfort, abdominal pain, some nausea. The capecitabine portion, the pill, can also give you a rash on the palms of your hands or the soles of your feet. So, that may happen. Needless to say, everybody's different. Some people receive the chemotherapy portion and do very well. Other people, unfortunately, develop a little more symptoms or side effects. And what I don't want you to do is compare yourself to other people because everybody is different. And the important thing here is try to stay on schedule. You should really try not to miss any radiation appointments or any chemotherapy appointments because we want to cure you. We want this disease to disappear so that you do not end up with a permanent colostomy bag. Okay? And that's, and I always tell my patients, listen, you have to prepare yourself for this treatment. This treatment is not easy. They're going to burn you in that area, in the perianal, anal, pelvic area. Okay, I call it a really bad sunburn. Now, some patients do very well, and some patients have more side effects. But I always tell my patients, listen, this too shall end. Try to stay on schedule. And if you're going to miss a radiation appointment or you're going to miss a chemotherapy appointment, it really should be for a very valid reason. We want you to stay on schedule because, again, we want to cure you. Always remember that. Remember, the goal here is to cure you and preserve that anus. We do not want that permanent bag. Now, this is another very important point. The benefit may be seen up to 6 months after treatment. So when you complete your chemotherapy and your radiation, the effects, the benefit of that chemotherapy and radiation can last up to 6 months. And that's something that you and your doctor need to keep in mind. So for those 6 months, what your doctor has to do is to monitor you to make sure that that cancer does not start to grow back. Because if it's starting to grow After chemotherapy and radiation, then obviously you're going to have to go to surgery. And yes, chances are you're going to require a permanent colostomy bag. But what I don't want is for you or your doctor to say, you know what, no, the cancer's still there, I still feel it, take it out, and then you end up with a colostomy bag before these 6 months are complete. Because remember, that chemotherapy and that radiation is doing its thing. It's working up to 6 months. So unless 6 months have not gone by, okay, wait and see if that cancer completely disappears. So remember, this is a very important point. I want to make sure you get this. If it's starting to grow back, it's growing, obviously you need to go to surgery. But if it's not growing, then try to wait up to 6 months, because again, the benefit is seen up to 6 months later. That chemo, that radiation are working up to 6 months. Notice how many times I've repeated myself, because that's a very, very important point that you need to always keep in mind. Now, the main side effects of this treatment, I already went over the dermatitis, the skin burn, so prepare yourself for that, the low blood counts, fatigue, bowel and bladder incontinence. Now, some patients have told me that the bowel and bladder incontinence really occurred only during treatment. Some people tell me it's lasted 6 months, a year. Some people tell me that 3, 4, 5 years out, they're still having some degree of bowel or bladder incontinence. It can happen, but you know what? I usually tell my patients, this usually happens in a minority of cases, but it can happen. And I tell them, you know what? That's the price you had to pay for being cured. It is what it is. It's a reality. Erectile dysfunction can occur. Infertility, I have had some young patients, and I always tell them, listen, this is a possibility. And the last one is rare. I don't want you to panic. I have personally never seen it or known of a case that I've been following, but there is a small risk of leukemia with this treatment. But again, very rare. Every type of treatment that we undergo has some sort of rare side effect or risk, so it's just something that you need to keep in mind. All right, so before we move on to metastatic disease, guys, like, share, subscribe. The best way that other patients can also benefit from this video is by finding it, and the best way is by you liking the video. So please hit the like button so other people can also benefit from this video. All right, so what about the treatment of metastatic disease, meaning your cancer has spread beyond just your anal canal or maybe local lymph nodes? So if you have metastatic disease, say you have anal cancer that has gone to your bone, to your lung, to your liver, then your doctor is likely going to recommend chemotherapy. And the most common regimen we use is a drug called carboplatin, which can cause decrease in your blood count, some nausea, and also paclitaxel, the same, hair loss, nausea, decrease in your blood counts. This combination is usually given every 21 days, although it can be given other ways. So, you'll have this conversation with your doctor, but it's usually given every 21 days. And the whole goal here is to shrink down the disease, keep you as comfortable as possible, and, extend your life as much as possible. And I can tell you some patients tolerate this regimen fairly well. Sometimes we may also recommend radiation. For example, let's say you have this anal mass. Remember, you can have the anal mass and you have cancer somewhere else in your body, but this anal mass may be bleeding, it may be causing obstruction, it may be causing pain. So sometimes we may also give radiation to the anal mass just to make you more comfortable. The other combination is, or the other family of treatments that we use are immunotherapy. And these are a family of drugs that stimulate your immune system to attack the cancer cell. The good news is that most people tolerate immunotherapy fairly well. I can tell you some people tell me that, they tell me, doc, it's like if you were giving me water. So that's excellent. Now, some people do have their side effects, but something that we monitor, but just know that immunotherapy is another option. The bad news is that it doesn't always work. It works very well in some patients and it works not so well on others. So it's a trial and error type of thing. So, just want you to know these are some of the treatment options for you if you have metastatic disease. Now, there are other chemotherapy options, and that's something that you can discuss further with your doctor. All right, now just some general information that I want you to keep in mind. If when you first presented, you had an anal mass that was greater than 4 centimeters, or you have involved lymph nodes, okay, meaning that your doctor tells you, yes, the cancer spread from the anal area to a lymph node, then obviously you're considered as having high risk disease. What that means is that, even if you receive chemotherapy or radiation for your local disease, you do have a slightly higher risk of the cancer coming back, or, of not being cured with the chemotherapy and the radiation, and you may require surgery. So just keep that in mind. The other thing is, if you have chemotherapy and radiation for local disease, and unfortunately the disease starts to grow, or after 6 months the cancer does not disappear, meaning it is still there, then of course your last option will be surgery, and then you will require what they call an APR. That's the surgery that the surgeon will perform, where you will require a permanent colostomy bag. So just something to remember. It's chemotherapy, radiation. If it goes away, excellent. The majority of the times they do. But if it does not, then you will require surgery with a permanent colostomy bag. Now, what about screening? I thought I'd throw this in there. Can you screen for this cancer to try to prevent this cancer from, or detecting it earlier, if you will? And the answer is yes. And who should be screened? Well, if you're HIV positive, consider screening. If you're a man having sex with a man, even if you're HIV negative, this is a higher risk population, so consider screening. If you've had cervical cancer or vulvar cancer, remember, a lot of these cancers are also due to the HPV virus. So of course, anal cancer, the majority, not all, but the majority are due to HPV. So you should consider screening. Remember, anal condyloma. So condyloma are genital warts. If you've had genital warts, those are also due to HPV. So, if you've had one HPV infection, you're at risk of developing another HPV related issue, in this case, anal cancer. And if you've had a solid organ transplant, also consider screening. These are things that if you fall in any one of these categories, just talk to your doctor about potentially screening and detecting one of these cancers very early if you were to develop them. All right, that's it. You made it. Guys, hit that like button so that other people can find it, and share the video. And I'll see you on one of my other cancer videos. Thank you.